I can't tell you the number of times I've circled the words dismissed. They
Oh,
felt that they were not listened to, they weren't believed, didn't respect them as human beings. And then there is this kind of overarching theme of negative interactions with caregivers. They felt that a caregiver was demeaning to them, yelled at them, was not kind or compassionate. And we know from the research that that is probably the biggest predictor of postpartum PTSD.
the essence of birth trauma. This is something that you just described as it's blowing up in such a way. Why do you think that is there more birth trauma or are more people identifying with trauma that has happened to them in the pregnancy and childbirth or even postpartum process?
I think it's both. I think we are starting now to raise awareness about how common birth trauma is, so more women are able to talk about it. We are starting to develop pathways to listen, maybe to get some of these individuals in for mental health therapy. So I think that's part of it, is that more people are talking about it. But I also think with the medicalization of childbirth and how how we are so geared towards interventions, and we're seeing more and more hemorrhage, for example,
Yeah.
those births tend to be traumatic for individuals. And we know that more and more of our patients are presenting to pregnancy older. They are sicker or have comorbid diseases. And I think by definition, we're going to see more physical complications, which can also be associated with psychological trauma. So I think we're seeing both. And
Yeah.
there, like I said, there's more awareness. So we're seeing it more in the lay press as well.
How do most people who maybe, let's say, I don't know, even 10 years ago, maybe they would say, oh, phooey to the birth trauma thing, but then maybe they have something happen to them that isn't what people are necessarily thinking. They're not, what we're not necessarily only talking about is hold her down. I've got to check the cervix and somebody shoves something inside of you or somebody does a procedure to you that you don't feel was fully consensual. That, of course, is a big part of birth trauma. But there's also women that go into the hospital. They say, I had a healthy mom, healthy baby. Everything was totally fine, but something didn't feel right. When you start working with them, and, my wife actually used a little bit of that language. I don't think she would ever use the word traumatic. Um, but I don't think she felt totally comfortable with how things went in the hospital, despite the nursing staff there knowing me as an OBGYN who used to work there, despite us being very close to our doctor, who was very hands off, an amazing doctor, Dr. Reed Nett here in Louisville, Kentucky. Something just didn't feel right for her. So when you start opening up the doors for women to talk about their experiences, what is the language that they're using so that maybe somebody who's listening can relate to this not just being the true obstetric violence maybe on the one extreme, but perhaps just some part about being in this medicalized maternity care system in the United States? What are they telling you? What have you been surprised by maybe?
Great question. When I see patients in my clinic, I take old fashioned notes as I'm talking to them. And when I hear certain themes or words come across, I circle them. And I can't tell you the number of times I've circled the words dismissed. They
Oh,
felt that they were not listened to, they weren't believed. People just blew them off, didn't respect them as human beings. Another
wow.
word that I hear all the time are feelings of helplessness and terror, which can accompany a lot of different emergency situations, fear for the life of their child. That that feeling of terror meets some of the criteria for a definition of trauma by the DSM-5, and so that's part of it. And then there is this kind of overarching theme of negative interactions with caregivers. They felt that a caregiver was demeaning to them, yelled at them, was not kind or compassionate. And we know from the research that that is probably the biggest predictor of postpartum PTSD, is feelings of helplessness, loss of control, and negative interactions with caregivers. So nobody tends to think about that.
Oh,
We think, oh, sure, someone had a major complication like bleeding or hemorrhage. Oh, of course, that makes sense to us. She would be traumatized from that, perhaps. but we don't think about our own behaviors as providers and the words that we're using and how
Yeah.
important they are. And instead of using the words to build on strengths that individuals have and the resilience that they have, we may inadvertently be harming them because of the words we are choosing to use. And so it goes unseen a lot of times because there's no box on the chart that says traumatized because people were nasty to her or to the birthing person.
Right. Right. Right.
It like you said, it doesn't get recognized as much as something else might, but it is definitely an underlying theme with a lot of the women that I work with.
What's up, everybody? It's Nathan, the host of your favorite podcast, the only OBGYN podcast that matters, the Holistic OBGYN podcast. So here's 3 things that you can do right now. Number 1, if you like these episodes, if you like the show, share it with people you love. They're probably going to like it too. The second is to support our sponsors. I've aligned myself with brands that make the best, highest quality products out there, all pertaining to fertility, pregnancy, postpartum, parenting, you name it. Support them, let them know that you're paying attention. And then third is that I want you to take a moment and click like. Let the Googleverse and the interwebs know that you're listening, that you're paying attention to the Holistic OBGYN podcast. Believe it or not, this really, really, really matters. So it's so important that I'm just going to take a brief pause right now. I'm going to let you go and click that like button. So just don't mind me. I'm just going to wait. All right. You've done it? Perfect. Thank you so much. I think I've said enough. Let's get back to my conversation. Yeah, I think I appreciate you saying all of that because we as physicians, we have long been revered for our capacities to care for people. And I think that the caring for people starts with the first time that they're coming to you and asking for your advice or your support. And when we dismiss that as like, oh geez, another one of these, or oh boy, another person with sexual abuse or whatever. Let's give this one to. I would always be the guy that got that because I was happy to just sit there and talk with them throughout all of residency. In fact, I was scolded because I would spend too much time talking to people, but I could tell there was something to this person's story. There's some part of this story that hasn't been told. And I actually think even from a physiologic level, I think this is going to perhaps cause some issues in the childbirth process. This is already scary. It can be exciting. It can be pleasurable for a lot of women, but it doesn't make it any less sort of formidable as this unknown thing that your body's about to go through. Your body's going to open up, release this baby, close up, and then now you're a parent. That's a really hard thing to go through. So understanding a person's story way in advance of this really exciting ride they're about to take and to minimize it down. I'm thinking about a roller coaster. It's like once you're at the top, there's no way you can say, I don't want to go
Yeah,
anymore. You have to go down the big hill. Um, I don't
yeah.
think that a lot of physicians remember that. I don't think that it's modeled for them. Now, you and I worked together when I was in medical school, and I remember seeing something a little bit different about how you approached people. Like they liked you immediately, and I was like, I want my patients to like me immediately. So how can I do that? And in residency, I remember them teaching us like we had like a lunchtime workshop on bedside manner. And I was thinking, shouldn't we have like somehow worked this out before we got to the place where we're actually MD on our chest or DO or nurse practitioner or CNM or
Right.
whatever? Shouldn't we have worked this out before we got to this place? But as a result of it being modeled and us practicing perhaps bad behavior, if we can call it that, I think it's hard to roll that back. So as an anesthesiologist, you're oftentimes you actually use these words, and you can correct me if you've changed, but you said, I'm kind of the ultimate customer service agent on the maternity unit because you're going in there and meeting them when they're at the
Uh,
peak of their threshold. I have had enough of the
right.
pain. This has been a really long induction, whatever. And you then have to kind of pick up where the OBGYN left off and make them like help them reground. So before they even get to your office, what are some of the strategies that you've learned or do you still teach residents, by the way, or med students?
I do. In a variety of settings, and I do a lot of
Okay,
trainings now across Pennsylvania and I'm being going
good.
across the country. Yeah, to teach
You're
about
on the
trauma
world tour.
awareness and yeah, exactly.
What are some of the things that maybe you can pull out of your training?
When I meet someone in my clinic, which is very unique, by the way, most anesthesiologists don't have that opportunity to meet someone in their eighth week of pregnancy, let's say, and have an hour to sit with them and talk. But the skills are similar, right? What's important is establishment of trust. I think in the culture we're in now with medicine, we have to shift from this concept of trust is a given. I think in the 50s, maybe physicians were revered and they we would come in and trust them fully to have our best interest at heart. Well, there are so many reasons why individuals, groups of people don't trust establishments. And now with social media, it's gotten even worse. And so we have to go into this with an idea that we have to earn trust. It's not just going
That's
to
right.
be there because I'm a doctor and you're a patient. It's not there anymore. And that's step one. And I think most providers have to get to that acceptance that, okay, I need to do something to work towards trust with this
Right.
person.
Right.
Right. So, how do I do that? And the first thing that I do with my individuals is to ask them simple things. How do you pronounce your name? What do you like to be called? Like, who are you? And how would you like me to treat you? So that's step one, super easy, right? Ask them. And then the second thing I do right off the bat is tell them who I am and what my role is in their care. So, like this, like the customer service person, sit down. Now, my visits are virtual, but if I see a patient in person, sit down at their level and talk to them like a human being. Introduce yourself. They don't always know who you are. And most of the patients I see in my clinic will tell me 100 people came into my room. I don't know who they were. Half of them had their name tags backwards, as if they all had permission to be there, but yet none of them really
That's right.
asked if it was okay
Yeah.
to be there. They just assumed they could come into that room. And so establishing what your role is, and then also saying to that person, this is a partnership. I'm here to guide you, but I also need to learn about who you are, where you're coming from. So, understanding someone in their cultural context and allowing them that permission to share and that it's a safe space and that you're not going to be there
Right.
to judge them. You just want to learn about
Right.
where they're coming from. So, those are the first 2 minutes of a conversation that can set someone off in the wrong direction or totally bring someone in to say, okay, this person's okay. I think I'm going to open up
Yeah.
a little bit.
Yeah.
Um, and I would say things not to do in the moment is to come in with a big computer if you're in the hospital, not even
Mm.
make eye contact and start asking somebody questions. Like that's
Yeah.
the difference.
Yeah. I think OBGYNs are in a tough place. I think people know me as the guy who really tries to push back on the training that I received or on the not necessarily even the training that I received, but the whole essence of medical education where I think we've kind of mixed up our roles a little bit. But in the defense of OBGYNs, you have to consider that 70% of the time they're doing surgery on people that have obvious pathologies. There's a 70-year-old African American woman who comes in with horrendous fibroids. Perhaps there's some concern for cancer. In that situation, right, you go into like problem solving mode, fix it mode. I'm going to use my golden hands and my sutures and maybe my laparoscopic instruments to help fix your problem. In other words, you're kind of on my turf. Like you came into my operating room suite and I'm going to take care of you, but this is how we're going to do it. Even in that situation, I think it really helps for a surgeon to help, to start building trust really early on with their patient. But in the maternity unit, you may have never met this person before. Like they may have never seen you because you're one of five people in a practice and you rotate call every 72 hours or whatever, which is unfortunately what a lot of OBGYN practices still do. It's not like where I trained at Kaiser where there's 50 people to cover call and you maybe do call once a month. So you go in on your Wednesday evening shift, you're making your rounds to meet everybody, and you are suggesting perhaps let's just spend 2 minutes building trust. Like that, the questions you asked are just basic human things. You don't need to go to med school to know, or you shouldn't have to go to med school to appreciate just the importance of that early bonding period with a person who's entrusted their health care to you. Um, do you think if you were to change anything about, let's say, medical school or residency education, what could we do instead of having a lunchtime bedside manner talk, which I think was completely ridiculous? Like we were all chuckling because it was ridiculous, but Kaiser was trying to get us there. What could we do a little bit better? Like, how would you like to see medical education change?
Well, one thing, and I'm writing this in one of the chapters in my book, is when we think about how we're trained, we take the disease, we learn about it from a cellular level, we build on it. What does it look like pathologically? What does it look like in the body? So we take the disease and then bring it out and superimpose it on the
Right.
person. And then that's how we're going to treat it. What if we flipped that and understood the patient more? Like, what if we learned more about behaviors? What if we learned more about what's it like to have trauma in the past? What's it like to live with racism in the past? What does that do to behaviors of an individual? And then put the disease on top of it. Like, all of our cures and treatments and interventions, they're of no use if we don't understand that a patient can't even get to the hospital, that a patient can't ride the bus, can't do X, Y, or Z, that the things that bring them to you, if they can't come to you, none of our treatments are useful, right? So I think maybe understanding behaviors, a little more psychological training, behavioral training, I think that should be at the core. I didn't learn that until I went to the Rape Crisis Center and took their training. And I thought, wow, that would have been useful had I learned that
Yeah.
15 years ago, right? Something very basic.
Yeah. Are you able to provide maybe some demographics as to where you're seeing trauma happening? Is it predominantly women of color? Is it predominantly women who do already have a history of some unrelated trauma? Is it socioeconomic, or are you seeing it across the board?
It's across the board. I've been asked this question before. It's different kinds of trauma. Women of color, they have chronic traumatic stress, a lot of them from chronic racism.
Yeah, yeah,
And they come to us, they distrust, but they've been dismissed over and over again. And they're hearing about how that is contributing to the maternal mortality rate for our Black women in that population.
yeah,
I see plenty of women of varying colors, socioeconomic backgrounds, wealth, education. They have different types of traumas, but they also come with previous birth trauma. And so that's
yeah,
another trauma we can put in there. Medical trauma from the past is another type. So it's across the board. I mean, trauma is
yeah,
pervasive, all different types. And I think that's why it's so important to have some training in trauma awareness and understanding, what does that do to people? How does that alter their health physiologically? How does that alter how they behave in the medical centers? How does that alter how they connect and understand their disease processes? And I just think because it's so pervasive, we all need that training.
You probably have some sense that after working with a person who did experience a birth trauma, when they are preparing or they go through a subsequent pregnancy, that things maybe go a little bit better. It's maybe not uniformly, and maybe we're tooting our horns a little too much. But why is that? Like, why is getting this trauma, talking about this trauma early and routinely, perhaps, for women who are ready to talk about it, of course. Why is this relevant and important for their future pregnancies, if it is at all?
Well, those that come through to see me and they're in that subsequent pregnancy, I think a lot of the preparation is about giving them a sense of control, giving that back to them. Because with any trauma, that loss of control is often a big part of it. And so letting them know that they have choice, they have control over various parts. Now, we know that there are some elements of a birth that
Many.
you don't have control
Yeah,
over.
yeah,
I tell new parents to be, just wait. You're going to become a parent. You're going to learn that your children we're going to do things that you don't want them to do even later on, and you can't
Yeah.
control everything. It starts when they're inside. But giving them a sense of control is important. Allowing them to have validation for what happened to them is huge. That's a lot of the work I do is giving them a space to tell their story. A lot of individuals never had that opportunity after their previous traumatic birth, after being dismissed with a chronic condition, after having childhood trauma. A lot of them never had a space to talk about it. That
Yeah.
alone is huge because then they have someone who's not going to say to them, "Oh, but you had a healthy baby. Let's move on. Let's talk about the logistics." It's, "Let me validate that for you. That was horrible, right? No wonder you felt this way." And we talk about it. And then we really dig in and talk about what was so bad about that in the past, because this is how we're going to intervene and make it different the next time around,
Right.
right?
Right.
If they tell me they really need to avoid an emergency situation, we talk about all the different pathways to say maybe a scheduled C-section is the right path for you. Right? So it's understanding their potential triggers for an upcoming delivery, giving them some say in what happens, thinking differently and more creatively about, hey, let's keep your significant other with you the entire time in the operating room if necessary. Let's break some rules. Really, there a lot of these rules are not really defined anywhere. It's just a practice habit that people have. But there are a lot of things that we can do that are simple, inexpensive, decrease the stress on the individual, and actually add a lot of reassurance and promoting that positive birth experience for the individual.
I had a woman reach out to me the other day and she said, enough birth stories. Like we're all tired, I'm tired of birth stories. And it made me really thoughtful and kind of feel a little bit sad about the the practice of storytelling, as a part of closing. It's a
Mhm.
closing ceremony to talk about your story, whether it was birth related trauma or not related, to birth or whatever, just something exciting that happened. There's that closure that happens that's like, oh, this is, um, I feel complete. I feel like I can move on. But because we've fallen out of the practice of ritual and ceremony around anything in life, for that matter, but especially the birth of your baby, I find that a lot of women who come to me, the first question I always ask, Tracy, which it's like I'm connecting with you telepathically, is tell me about your previous birth, especially if they had a really hard time in the hospital. Just tell me your birth story. 50-50, they're going to end up in tears and they're going to thank me afterwards because they haven't had the opportunity to tell that story. So I think that there is therapy in that alone. Um, I want to change gears a tiny bit. Of all of the tools that we're starting to see utilized within clinical medicine, the psychedelics and ketamine conversation is quite interesting, and MDMA is quite interesting to me. Have you explored any of those modalities for people who have had horrendous traumas in the past, and maybe as a means of facilitating that closure or working through or out of that trauma?
I personally have not done that, not yet. Somewhere down the road, I'm hoping to get some more training in these trauma interventions. But I do refer patients whenever I think it's necessary for EMDR, which is kind of a non-medication type of NMDA,
Is that the, like, eye something with eye movement, like, or tapping or
eye
something?
movement.
Is that what it
Yeah.
eye movement, okay, gotcha, gotcha.
Eye movement desensitization and reprocessing. That's the what it stands for. But
Wow,
it can be done with lights. It can be done with movement. It's really going from right side of the brain to left side of the brain over and over. And from what I understand, it
wow,
relaxes the brain a little bit so that people can then do cognitive behavioral therapy and talk about their experience without all the physiologic response, like feeling sick, that visceral sickness that comes with it. So it helps them to talk through it and feel safe. I think that some of our psychedelics do something very similar, and I have heard great things
sure.
about them. So I'm hoping that that can be something that's offered. as well as the EMDR and the cognitive behavioral therapy. Now, ketamine, we just had a recent conversation about ketamine. I think the verdict is still out.
Okay.
And for some individuals, ketamine, if it's used with not the right dosage for someone with known PTSD, may not be the best drug. I've had patients come to me who had horrific hallucinations. They dissociated. They didn't feel like themselves. They didn't feel like they were part of the birth experience. So I think it has potential, but we're just not sure the right way to use
Yeah.
it.
Yeah.
I have used it for my individuals who have opiate tolerance, who also we know most likely have come from trauma, but very, very low dose as a background infusion during a C section to help with pain relief, but not enough to cause that type of
Wow.
psychological disruption.
So you're using it for its anesthetic properties as well, the ketamine.
Mhm.
Wow.
Yes.
During a C-section,
Mhm.
I don't think I've ever thought about that or heard about that. And that would be for a patient who does have a history of opioid abuse, or I don't know what the right word is nowadays, but opioid, let's say opioid tolerance in the very least, that you know you're not going to get the
Yeah.
most bang for your
Mhm.
buck from a spinal anesthetic. Is that why you chose that?
That is correct. We try to bring in as many different modalities as we can, other than using additional opiates if we think they're not going to be as
Right.
effective. And we want to have good pain relief for them. So, yeah, we've tried ketamine. There's some good evidence that works. Again, staying on the lower end of the dosing parameters because I don't want to see these individuals get to that point of
Yeah.
dissociation or not
Yeah.
remembering. Because one of the things that I explain to my patients all the time is we might need to give some medicine for anxiety in the operating room. And there are some safe choices, but we want to keep it as low as possible because in order for them to get post-traumatic growth and healing from a positive birth experience, they have to remember the birth experience. So I run this fine line. It's like a tightrope. I don't want them to have so much terror that they are dissociating or on the ceiling from panic, but I don't want to give them so much medicine that they are asleep, sedated, and they don't remember anything. So, working with them so they accept a level of nervousness, but know that it's because we want them to remember that everything else around them is
Yeah.
positive. So, but I think there are definitely some potentials. Now, back to using some of these medicines like immediately after a traumatic birth, I'm exploring more and more about is anybody doing research in this area? If we know someone had a significant hemorrhage, for example, we know that increases their risk for postpartum mental health issues. Should we automatically be doing EMDR before they leave the hospital? Would that help? Could we use some of these psychedelics within the first week? Would that help? There's some evidence out there that steroids given in and around that time might actually decrease the risk for PTSD. So all of those might come into play, but again, we don't know enough yet. Research is just being done, just coming out, but I'm hopeful that we might be able to add some help on after a traumatic event has occurred.
Yeah, I wonder. I mean, everything you're describing with regards to something happening
Mhm.
between the left and the right side of the brain. We're looking at is it called the corpus callosum? Do I remember that correctly? Where fibers cross
I
over.
think so. Yeah.
So there's this.
Yeah.
So you've got your left hemisphere,
Mhm.
your right hemisphere for people listening, and those two hemispheres they communicate through. I believe it's called the corpus callosum. I'm not a brain guy, but um, with the EDMR, what is it? EMDR? Is that what it's called again? I've heard it so many times that I get
EMDR.
okay.
Right. Mhm.
EMDR. We're like it's like we're relieving some sort of traffic jam between the left and right side of the brain. But even unilateral exercise and whatnot, like trying to focus on um, like for example in an exercise setting we know that exercise helps with depression, anxiety, etc. It could be that perhaps that is doing something to the brain. This movement, this proprioceptive awareness perhaps helps to get that junk out of the way. And it doesn't surprise me that something that is so disassociative like ketamine might actually help with that as well. Like let's get you away from that, let's let that
Mhm.
traffic jam clear up, and then we can go back to normal functioning. It's
Yeah.
it's it's quite. this is obviously the way that Tracy and I are speaking. This is obviously an area that requires quite a bit more clinical, let's say, investigation before we can say for sure why these things happen.
Right.
But to sort of turn another corner, you mentioned something that I want to close with, which is that if they're going to heal from their trauma, and I'm going to replace that word, I'm going to say, let's say, heal through their next birth. I know that you and I have talked a little bit about that. Can you describe that? What do you mean when you say that that birth can be a healing experience?
Well, I can say this through the words of the patients that I work with. Right? This is how they describe it. It is life altering. They have such a positive experience, and they see now how good it can be. And I think also if you allow them that empowerment through their work leading up to the delivery, they know that that's all them. They did this. They worked through their fears. They were able to advocate for themselves. They were able to talk about their previous experience. They own
Mm,
that. They did it. And then they also have that, I would think it's a rush of this positive emotions that flow, hopefully in this setting now where there's not so much fear, last lack of control. They also get probably more release of that oxytocin. They might even get
wow.
to do that bonding a little bit earlier. All of the physiologic things are happening in a more positive direction. The respect that they have from others, and then they feel for themselves. Like I said, it's an
Mm,
empowerment. And I think all of those things go together to help them afterwards. Um, I just
yeah.
think they're on such a different trajectory after that next one. And that's something that we're following. We're getting ready to do some analysis of data. So the people that I've worked with, we want to see, does this kind of preliminary work and getting them a positive birth, does that equate to decreased symptom severity for mental health symptoms, let's say? If they have anxiety or depression, do we see that to a lesser degree then afterwards?
Yeah.
Does it allow them better pain control because they had a better experience? We knew about them, we knew about their needs, we met those needs. Does that mean that they use less opiates? Yes. I can tell anecdotally, absolutely. These patients do really well. They make less visits to the emergency room. They know they have safety nets built in. They know who they can reach out to if they need something. It's really a different, it's totally different for them.
I've had a number of women who have described exactly what you're describing, and they went the way of home birth, which is a large part of my community because I'm an
Mhm.
advocate for home birth for many women. They come to me with, these stories, and I can't tell you how many women who have described that in the way that you just, related to me after having a home birth. And the reason they chose a home birth, even if it was like after previous C-section, like they're going all the way over in the other direction. They've described it
Yeah.
as healing in ways that they don't feel they could have achieved with the number of interventions that happen in the hospital, with the way that they feel dismissed, the number of eyeballs on their naked body, like all of that just didn't feel right to them.
Yeah.
So in the home birth environment, of course, it's very different. But to take it one step further, I've actually had women reach out to me and say that through my birth, whether it was in the hospital or home, I don't remember, it's not relevant. I was able to kick the resulting uh, sort of I don't want to say pathology, but the resulting symptoms of a childhood trauma that I had. And the words that they've used, Tracy, over and over, like you circle words on your paper, the words I circle
Mhm.
are that I feel like I healed my trauma from my childhood abuse when I became a mother through having an autonomous birth. And that autonomous word was really important to them,
Mhm.
that I got to make decisions for me, for my baby, and I owned the outcome, which, in their case was a beautiful baby on their chest in their bedroom, just like my wife and I had a little over a year ago. So, this healing through an otherwise traumatic experience, which in some ways birth is going to be traumatic no matter what. It's the integration of the experience, I think, that results in long term trauma versus just that was really stressful and exciting. And of course, if you have closure, and whatnot, it doesn't have to be traumatic. But the way that it's treated like a medical procedure doesn't seem to lend itself to that healing experience that so many women describe. And it all starts with them having planted their ground firmly as a strong woman. And that old person was allowed to die. That person who was traumatized as a child or taken advantage of or abused in some way, whether it's at the hands of a doctor doing an unnecessary episiotomy or something like that, they were able to let that go as a result of owning and partaking in this beautiful undisturbed birthing process, which I find is a pretty compelling reason for people finding their way to home birth or even a birth center birth. So I'm going to give you a hard question now. Is the only way for us to heal from birth trauma, well, if we want people to have that experience, should we as an industry start to rethink the necessary nature of having a baby in a hospital with all of the blinking lights and the beeping machines and everything? What do you think?
I'm definitely in favor of home births for the
Yeah,
right individuals, the ones that we know meet criteria that to be safe to do that. Absolutely. Do I think we're using too much intervention, too many lights and beeps? Absolutely. My vision would be to create some sort of a
yeah,
hybrid where, and let's face it, the majority of individuals still
yeah,
deliver in a hospital. And even those that choose to deliver in a birthing center, let's say, they may choose that because they have long-standing chronic traumatic stress. They may be
right,
the ones to develop hypertension
right.
and need to be then transferred to the hospitals at 35 weeks, where they then know no one and they're put in this awful environment. It's a problem.
Yeah,
I would love to see everything get shifted and we get rid of so much of this tethering and monitors and lights and medicalization. I'd love to see a hybrid. I'd love to see a hybrid type of anesthetic work for people. Bring back the walking epidural so patients can still just get something little. Those that need it or truly want that, because
yeah,
pain for them is a trigger and they need some help. But let's not give them something that they're forced to stay in bed. Why not just do something that they can still move, still feel like they're doing a lot of the things they need to do? I think there's a lot that we can do. We just we need to change the culture and how people think it has to be done.
yeah.
That's the hardest part, is changing a culture. A lot of the work I do are simple, inexpensive, as I mentioned, interventions. No fancy equipment. Just takes the providers to switch gears in how they approach patients.
Right.
And honestly, that is the hardest thing to change. But I do think we should be supporting more of these home births. Again, if they have the right environment, it's safe to do so. We need more of you out there, that if you attend to these home births, you have this experience. Um, it's a beautiful thing. It is.
Yeah.
But for those that are delivering in the hospital, my goal is to try to create that environment that mimics your home births, but tries to get them that same sense of accomplishment and empowerment and autonomy over their choices, right? But especially if they have to be in a hospital setting, especially in an operating room, which is the most sterile, foreign, terrifying
So
environment
alien.
for almost anybody.
Yeah.
Yes, it's terrible. I mean, I've started bringing women in to get a tour of the operating room. I've done virtual tours with them, and it helps. It really helps so that they can make it their own.
Yeah.
It's not their bedroom, but we talk about what can we do to make you feel like it's safe,
Yeah.
and we can put blinds on the windows and we keep them covered with the Vogel spa method, as I call it, things like that. But again, it's just trying to mimic what the ideal would be at home,
Yeah.
like what you're doing.
Yeah.
It's going to take an army, and it's going to take all our researchers out there putting out this data to show that women will do better if we do X, Y, or Z and change our approach.
One final question, Tracy, because you are an anesthesiologist, you specialize in obstetric
Mhm.
anesthesiology, which is, you're a rare breed. There aren't that many people that really go the extra distance to
Mhm.
focus on that. Some people like it, but you really have like doubled and tripled down on
Mhm.
your experience with maternity care. Do you can you just real quickly talk about in your dreamscape, you've got all the resources, you are the king of the castle, the queen of the castle. What would you like people to know who are on the healthcare side about how we can improve the C-section experience? What would you love what is the best scenario based on your understanding of the procedure and what women are telling you after they've gone through perhaps a I feel like every C-section is a little bit traumatic. It's just a hard, really hard thing to go through, but it doesn't have to be. Perhaps what would you like to see change in those operating rooms?
First of all, I'd say let's think about the environment itself. There are some physical things that can change in operating rooms. They don't have to be stark
Mm,
white. They don't. We can have the walls painted a slightly different color. Right? The temperature can be changed, keeping patients warm. I also think about what works well that I've seen is, again, keeping that significant other with the individual. Do not separate them, not even
mm,
for a spinal or an
mm.
epidural. No to arm straps. Like the individual is going to be rendered paralyzed from the breast down. So let's keep their arms warm and cozy on their chests. Plan for that ahead of time. Have the significant other holding their hand or right there with them at the head of the bed. I think the room needs to be calm and quiet. So we have to minimize traffic. We do not need 16 people in an operating room for a scheduled C section. I've counted that many before.
16.
16. And it's because we have so many trainees from the NICU teams, the nursing side, the anesthesia side. Maybe we need to focus on just having a certain number in the operating room. So minimizing traffic and only have those people in the room that the individuals know are going to be there. Maybe even
Yeah.
have them meet them ahead of time, just even to say hello. This is our person who's going to be handling the instruments. She's wonderful. Here, meet the patient. Right? Everyone should meet them. Even residents should not be saying hello for the first time when an individual is on the table with the spinal kicking in. I don't think that's appropriate. Um, I think we need to focus on what I call trauma awareness standards, but it's also part of our ERAC, as we call it, early, um, what am I thinking? Early
Early
recovery
recovery
after
and yeah.
cesarean. After surgery is the ERAC,
ERAS, yeah.
but it's the same principles. Yeah, ERAC, as we call it, is making sure our individuals are not nauseated. And we can do that. We have all the technology now. They should not be vomiting after a spinal. It's horrible for an experience.
Yeah.
Keeping them warm with as many modalities as we need to. Taking care of pain, which is a big one. Anticipating who's going to have altered pain thresholds, especially if they come from a history of anxiety, previous birth trauma. They might need something different or something, a higher dose of something, because they're going to perceive pain a little differently. I personally think we should be using an ultrasound for spinals and epidurals just to give us even more chance of having a very simple procedure, not traumatizing them with the needles and getting better outcomes. Testing to make sure that this anesthetic is perfect or as close to perfect as we can get before we let somebody start,
Yeah.
which means, again, slowing things down when you can. Right? Just take a moment to make sure it's good, especially if that woman or birthing person wants to be awake. We owe it to them to do everything we can to prevent general anesthesia from a failed spinal or epidural. When that's possible. Anxiety. I'd love all providers to know that there are safe medications out there, safe doses. I think some are still living in the past where they were taught don't ever give anything until the baby's out. Well, a person could have already dissociated by then from sheer terror. And these individuals need that. They need that for blood pressure help. They need that for, their tachycardic, their breathing fast. That's not good for the uterine environment
Right.
today.
Right.
So considering all of those things to help somebody have a better experience in the operating room and then get started right afterwards with early eating or drinking something in the recovery room. So And then, of course, optimizing everything for early skin to skin bonding in the operating room. Get this family together if that's what they want to do, how in whatever framework they have in their minds, whether the dad's going to hold the baby or the mom wants the baby on their chest. We should be doing everything we can to
Yeah.
optimize that chance. But it takes focus, it takes attention to details, and it takes
Yeah.
time. So I guess my wish would be for everyone to have a little more time with each individual patient in order to be able
Yeah.
to do that.
Tracy, thank you for doing this interview with me. Can you let people know real quickly where they can go to find your practice and anything else you want to close with, I suppose?
Well, if anyone needs to find me from outside of Pennsylvania or even within the state, my website is theempowermentequation.com. And people can reach out to me through that, through a quick email. The clinic at Allegheny Health Network that I run, I have a number. Patients can self refer if they want, if they're in my area. And I'm just going to give the number 412-526-9520. And you don't even have to be delivering at Allegheny Health Network, but if you want to talk to me, I'm available. I do hear from patients sometimes from across the state. It's been interesting.
Yeah. Well, hearing that 412 number certainly gives me a little butterfly in the belly. Uh, you're in my hometown of Pittsburgh, in case you guys weren't able to guess. Tracy's at one of the big hospital systems in Pittsburgh. And as far as I know, UPMC does not have a program like this. I don't know if any hospital has a program like yours. That's a pretty unique place for people to get help. So if you're listening and you want to know more about Tracy, or if you want to support her work, or if you need her help, give her a ring, find her online. And Tracy, in the meantime, thanks again for giving me so much of your time. And I hope you have a great day in clinic.
Thank you so much. It's always a pleasure to reconnect with you, Nathan.
Likewise, the feelings are mutual.